So today, our topic and our speaker is Dr. Noni MacDonald, and the topic is moving from vaccine hesitancy to acceptance. And Dr. MacDonald is a professor of pediatrics infectious diseases here at Dalhousie University and here at the IWK Health Center in Halifax. She has three major areas of interest, one being vaccines and especially vaccine safety and vaccine hesitancy, and through her work with the World Health Organization and vaccine pain mitigation and policy. She has another interest in micro-research and building capacity in community-focused research in developing countries, and I think you will be able to see the website there for that. It's www.microresearch.ca. And then a third interest is the application of health information systems in developing countries to improve health outcomes. She's published over 300 papers. She's a founding editor-in-chief of Pediatrics and Child Health and a former editor-in-chief of the Canadian Medical Association Journal. She has long been recognized in Canada and internationally as an advocate for children and youth health and as a leader in pediatric infectious diseases. Immunization is recognized as one of the most important and cost-effective public health innovations. Immunization programs in Canada have made significant contribution in the reduction of morbidity and mortality in children, adults, and other vulnerable populations. But despite this evidence of benefits and safety, there remains a hesitancy among some individuals to have either themselves or their children vaccinated. So Dr. MacDonald is going to address some of these challenges and benefits today, and specifically she will define vaccine hesitancy, outline factors that influence parental acceptance of vaccines, describe the effective approaches to addressing the hesitancy at the program and individual levels, and list vaccinology resources that parents, patients may find helpful, and certainly care providers as well. So, Dr. MacDonald, I'll turn it over to you now.
Thanks very much, Darlene. So this is a fairly complicated topic, which I'm going to try to give you some of the important highlights for in this talk today. It is becoming a globally recognized problem, and I think that we're being timely by talking about it here on this network today. There we go. I have no financial conflicts of interest to declare, but I do have biases. I actually believe vaccines are safe and effective, and serious diseases can occur if you're not immunized. You need to understand that, bearing in mind what I'm going to say after this. In other words, I am pro-vaccine, not anti-vaccine. The objectives, Darlene's already gone over them for you. Now, this is a very interesting interactive map that the Huffington Post published last fall, and you can go and find it at the website noted below. It's actually kind of a scary map for a lot of us. This shows the vaccine-preventable disease outbreaks globally between 2006 and 2014. And you can see that there are examples of vaccine-preventable disease outbreaks all over the globe. And I think a lot of us would think of these being particularly prominent in Southeast Asia and in Africa, but as you can see, there have been big outbreaks in Europe, and we certainly have had our outbreaks here in Canada. Now, as many of you know, we've had this outbreak in Quebec that they got from the Disneyland contact. There have been 136 cases of measles in the Laurentière region of Quebec by mid-March this year. In the U.S., they're reported by January of 2005, there were 95 cases of measles in 14 states. It's now well up over 200. And in 2014, they had a record number of 644 cases of measles, and this was a disease they thought they had eliminated in the United States. The map of California there gives you the dots about personal belief exemptions. And as you can see down here around the LA region, heavily dotted. In other words, there are many, many people in the Disneyland area who have not had their kids immunized more than 5% because of personal exemptions. And in the Quebec region, many of those patients who got measles had not been immunized. So what's going on here? Well, vaccine hesitancy has been such an important problem that the World Health Organization's Strategic Advisory Group on Immunization, who set global policy internationally, formed a working group on vaccine hesitancy in 2012 that I was fortunate enough to be asked to be on it. And I'm going to present some of the findings from the WHO SAGE working group, who presented their report in November of this past fall. So first of all, what is vaccine hesitancy? Well, it refers to the delay in acceptance or refusal of vaccines despite availability of vaccines. It is not about not having the vaccines out there. So if we, for example, here in Canada, we have some provinces that don't have publicly funded rotavirus vaccine. Well, you would not be hesitant in those provinces if you didn't get your child immunized because it's not publicly funded. You would be hesitant if you didn't get your child immunized against rotavirus in the provinces who do fund rotavirus vaccine. Vaccine hesitancy is complex. It's context specific. It varies across time and place and vaccines. So you all know in the fall, when there was this big hype about the Ebola vaccine being developed, we were overwhelmed here at the IWK with people who wanted to volunteer to be part of that investigational trial. And in other outbreaks, people have lined up to get vaccines. In other words, context matters, time matters, and the vaccine matters. Vaccine hesitancy is influenced by factors such as complacency, convenience, and confidence. I'm going to talk about those in the next slide. The thing I want to show you here is there's a continuum from accepting some or all vaccines but having some doubts, all the way down to refusing all, but maybe you accept one vaccine. That whole continuum is vaccine hesitancy. And as the WHO has said, this is a problem in high-income countries, in middle-income countries, and in low-income countries. So what do I mean by confidence, complacency, and convenience related to vaccine hesitancy? Well, confidence is about having trust in the vaccine, in the delivery system, in the policymakers who decide what vaccines are going to be available, and in the people who give the vaccines. Complacency happens when people perceive that the vaccine-preventable diseases are very, very low risk, and I don't need to pay attention to those. And other things that are going on in my life or in health care are way more important than my paying attention to getting vaccines into my child or my family or even into myself. And convenience is about physical access. It's about availability. It's about affordability. It's about willingness to pay. It costs people money and time to get out to your family doctor to get immunized or to go to that public health clinic to be immunized. It may be a matter of language that's a problem. It may be a matter of how appealing your immunization services are and how difficult the hours are when you're open to get immunization to be available. So if you look back at the anti-vaccine website, anti-vaccine tactics, these have been going on for a couple of hundred years, ever since vaccines were invented in the late 1700s. And they really follow 4 different ways that they attack vaccines. First of all, they skew science. They deny or reject any science that fails to support their anti-vaccine idea. Then if we've shown so much evidence that they have to reject that idea, they just shift to a new hypothesis and says, well, it may not cause that, but you know what? It causes this. And so it's an ever-moving target for those of us who immunize. Then they do censorship. They suppress dissenting opinion and they shut down critics. So it's almost impossible to have a public dialogue with anti-vaccine people because they don't want you to put your data out there very well. You can do this in private, you can have the conversation with a person, but when you're in public at one of their events, they don't want to hear you. And the other thing they do, and they do it quite ferociously in some countries, is they attack critics by personal insults and by filing, in the U.S., for example, legal claims. One of the things that's happened to me when I've given talks in the U.S., I've had vitriolic emails sent to me following those talks from anti-vacciners. It's not pleasant. So why does that happen? Why do they ignore the science? Well, it's called assimilation bias. It's like having a do not disturb sign on your head. If the fact is consistent with what you believe and you're an anti-vaxxer, in will go that fact. But if the fact conflicts with this anti-vaccine belief, it gets rejected. And what our job is is to reshape that fact and that piece of science so that it can slide in and start to change those beliefs. You know, many of us would like to say that all of the major decisions that we make are based on evidence and our careful sifting of the facts. But what we actually know from psychology literature is that's not true. We make most of our decisions based on our gut instincts or our beliefs. Why do we do that? It's because we're hardwired to do that. That's why we are all alive and why we survived over the multiple millennia that humans have been alive. We're hardwired to deal with life-threatening situations with reflexive reactions. It's called heuristics or cognitive shortcuts. It's the automatic intuition or your gut instinct about what you want to do. And you don't even know you're doing this. And we all do it. Doesn't matter who you are. So how does this affect vaccines? I'm going to give you a couple of examples. So one of the cognitive shortcuts we use is called anchoring. So we estimate by starting from a value you know, the anchor, and judge the probability of future event by what occurred in the past. So if you have heard of somebody who had a serious adverse event following immunization, you think they're far more common than what they really are. And then one that's very important for new vaccines is called omission bias. Actions are more harmful than inactions. And that's why when we put a new vaccine out there that hasn't been used before, people are more reluctant to start than they are to ignore that immunization and pretend because it's brand new. Availability is how we judge an event as frequent or likely to occur because we can recall or imagine it. And this is where stories can be very powerful. And that's why the anti-vaccine websites and the anti-vaxxers, when you hear them, are always telling you stories because they are very powerful. And that's what you remember and you recall are the stories, not the statistics. So where do parents and others get their vaccine information? Well, the Vaccine Confidence Project that Heidi Larson from the London School of Tropical Medicine has done, she looked at, in 2012, and in 1 year globally, there were more than 10,000 media events about vaccines in 144 countries in just 1 year. We know in 2010, more than 80% of households in Canada had access to internet. Listen, by 2015, we're probably at 99%. And 80% of people seek health information off the internet. And they really, really like what's called user-generated content, or Web 2.0. Web 2.0 means I can be the expert if I go onto a blog and say this is what I believe. And many people out there really like those chat lines and Twitter accounts. So now you can have a big, big audience for a lot of the fringe beliefs the anti-vaxxers have because they know how to use social media really well. For immunization, we have a problem because if you go to Google, for example, and search for vaccines, up will come the anti-vaccine websites before the pro-vaccine websites will come up. Well, does it matter if you find one of these anti-vaccine websites? You bet your donuts it does. Because of biased assimilation, it changes how you perceive the risk. So we know from a study that was done in Germany that increasing 5 to 10 minutes on an anti-vaccine website increases the perception that vaccination is risky, decreases your perception that omitting a vaccine has any risk at all, and it changes your intention to vaccinate. We know for blogs, for human papillomavirus, that they're full of stories, the vaccine critical blogs. These ones increase your perception that the vaccine is very risky to take, and it decreases your intention to vaccinate. Now, if you look at HPV videos on YouTube, in 2008, most of them were positive, but by 2011, half were negative and a third were neutral, and the rest were neutral. And now, the majority of them are negative. So this is very problematic for most of us. So one of the things that happens because of this, and I love this table from this paper, in the United States, 49% of Americans agree with at least one conspiracy theory. 18% agree with at least 3 or more conspiracy theories. And if you believe the conspiracy theories, you are much more likely to avoid traditional health care, including vaccinations with things like influenza. So your social network that you network in and what your patients network in very much influences your beliefs and actions. And if you're in a social network that believes conspiracy theory, you are much less likely to come forward for vaccination. We don't have Canadian data on this, but I do think, I hope we're not as into conspiracy theory as the U.S. is, but I do think we do have some problems in some parts of Canada with exactly this kind of bad thinking. So what did WHO do? Well, we did a systematic review looking at all the strategies that are out there to address vaccine hesitancy. And sadly, I have to tell you, there's no magic wand. There's no silver bullet that's going to fix vaccine hesitancy in every context for every vaccine, anywhere it's going to be found. So there were no strategies to specifically overcome hesitancy in all populations. There are strategies, though, that do improve vaccine uptake, and we do know that multi-component strategies are more effective than single-component strategies. So what can we do about this? So I'm going to go over these 10 strategies. The first 5 are program immunization level strategies. The second 5 are individual patient-oriented strategies. And it's always important, if you're going to put one of these strategies into your program or into your practice, that you look to see how you evaluate what came out of it and did it work. So let's look at the first program one. This is called the Guide to Tailoring Immunization Program, or TIP for short. This was put together by WHO Euro. You can get it online at the website that's noted down here. And this is how it was reviewed in the SAGE Working Group report. One of the big things in here is, don't assume you know why you've got low uptake of vaccine in your population that you're looking at. You need to identify and prioritize the vaccine hesitant populations and the subgroups. Everybody's not the same. That map of California showed that everybody was not the same. You need to diagnose what the problem is and then specifically address that problem. And there's a lot of evidence now coming in from Europe to show that when you do this, you actually can change hesitancy. And then, of course, you need to evaluate the impact and the outcome. And if there's time later, I can give you a couple of examples of populations in which this has worked. So we do know that you should be using the immunization program interventions that are most effective on increasing uptake. So what are they? First of all, directly target the population. Very much the same as what Tip was saying. Look for the unvaccinated and the undervaccinated populations in the communities that you're serving. Look for specific populations. There may be a local sub-community by religious belief or something else that you need to tackle. Aim to increase knowledge and awareness about vaccination, although we know knowledge is not enough. Improve convenience and access. This I can't say loudly enough. Too many of our vaccine programs set it up so that they are provider, that's like you and me, convenient, and are not necessarily that convenient for mothers of young children or adults who need to be immunized. I think it should come as no surprise to us that when vaccines now are given in pharmacies, how much better the uptake is, because you have a much higher probability of dropping into a pharmacy than you do dropping into a public health nurse's office or clinic or doctor's office. We also know that employing reminders and follow-up really does improve people coming in to get immunized. It's also helpful to engage religious leaders and other influential leaders to promote vaccination in the community. There's a study out of Israel when they had the wild polio virus in the water. The Orthodox Jewish population there do not take vaccines at all. The Israeli Pediatric Association and WHO work closely with the rabbis for that community to actually change that practice so that many, many, many came forward to get immunized against polio, and they stopped it from becoming an endemic problem there. I'm not going to talk too much about mandating vaccinations. This is a very complicated area, and it can backfire on you in that if you're one of those conspiracy theorists, they make you think that the government's coming out to get you, and it actually backfires and they become more anti-vaccine than they were before. In Canada, we do have 3 provinces where vaccine is mandated to go to school. You have to show what your immunization rates are, and that's BC, Ontario, and New Brunswick. But I wouldn't say we've got data in Canada to say that they have such stunningly better immunization uptake rates than the other provinces to say that this is the best route to go forward. But it is certainly something to consider if you're looking to increase healthcare worker vaccine uptake in hospitals, because there's huge data to show that it makes a big difference if you mandate it as opposed to being voluntary. So the third point from a program point of view is using effective communication tools to address hesitancy. What do I mean by this? Well, first of all, it has to be targeted. The communication tool needs to fit the audience targets you're going after. You need to be proactive, not just reactive, and because of that, you need a communication plan in place so if something does get out of control, you are able to get at it right away. It has to be a two-way process. You need to be listening to your communities to find out what their concerns are, not just telling them what you think they want to know. And we do know that knowledge is not enough. It's insufficient to change behavior. There are many models that have shown that you're going to do better if you exploit those cognitive shortcuts. I'm going to talk about that in a minute, that I talked about a few slides ago. So what are some of the tools you can do? You select a tool to fix the target. It may be mass electronic media, can be digital media, print media, social mobilization, mobile technology, service-oriented communication, all different strategies. You need to pick the ones that are going to fit your communities that you're trying to address. And part of what you're trying to do in vaccine hesitancy in addressing it is, if you already have people that are accepting vaccine, you want to make them a more resilient population. So you want to support them in their pro-vaccine beliefs. I'm going to talk a bit more about that in a minute. So what did I mean by exploiting cognitive beliefs? This is about telling stories. So this is about telling stories, healthcare workers, putting those stories out in your social media, having parents tell their own stories. There are some very, very powerful stories out there. I don't know how many of you have seen the UK video on meningococcal disease, Charlotte Nutt's story. And if you haven't seen Anne Getty's beautiful book on portraits of meningococcal disease, it'll blow you away, and the stories as well. And once parents hear those kinds of stories, they anchor and recall on these things. Now, if you don't have your own stories, you can find many of these stories at Immunize Canada and also at immunize.org. So one other point I want to say about social media and the internet. Listen, we have anti-vaccine websites all over the place in many, many countries. But I want to tell you what they did in Australia, and I think we need to be thinking about this too. So the New South Wales Fair Trade Tribunal got so many complaints about the Australian vaccination network saying that this was false advertising because it made it look like it was a very balanced look at vaccination and anti-vaccination, which it wasn't. It was actually an anti-vaccine website, and that was what they were promulgating. So the New South Wales Fair Trade Tribunal charged them and said they had to change their name. While they were waiting to change their name, they had to put this on their website, which says that New South Wales Fair Trade Tribunal directed it to change its name because it regards the name to be misleading, blah, 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 blah. And it went to an appeals court. They lost the appeal last March, and they therefore had to change their name. It's now the Vaccination Skeptics Network, a big difference, I think. And they lost their charitable status, which many of these anti-vaccine websites have, because you're not allowed to be a charitable status if you're actually a political entity. And this was deemed a political entity. I mean, small p political, but still a political entity. We haven't taken any of our anti-vaccine websites on in Canada or in the UK or in the United States. And I think maybe because this law is now out there as an example, we should be thinking about it. So what about the impact of the vaccine messages? This is a paper that came out in NIHAN, by NIHAN last year. And when it was reported in the media, they emphasized the group that if you didn't believe in vaccines, you were unfavorable to vaccines here, that when you heard this media about vaccines being a great thing, it just reinforced your anti-vaccine thoughts. In other words, it backfired. Remember I told you the assimilation bias? That's what happens with backfire. It just makes them stronger anti-vaccine. But what never got talked about in that paper and in that publication was that for all of those who were out there that were pro-vaccine, these favorable vaccine messages increased their sense of positiveness about vaccines. So it supported resiliency. So this part got left out and wasn't even discussed in the paper, and I haven't heard that much about it, but it's telling us that we really do need those pro-vaccine messages out there because they help make our many parents who do immunize stay strong and be resilient. Key message from this is tailor your message to who you're talking to. There's another study that showed that targeted may even work with the hesitant. So vaccine hesitant mothers of 2-week-old babies were given a video and information, and it increased the uptake of vaccine for those babies at 6 weeks of age. My last point I want to make from a program point of view, and some of you have heard me talk about this before, I really think we need to be shaping young people's beliefs about vaccine necessity, vaccine benefits, and vaccine safety. We need to start in primary school and on into secondary school. We need to engage the teachers, engage the students, and we need to put resources together to be doing this across Canada. Why? Because this is how you shape beliefs of adults. You shape them when they're children. And we know this works because evidence has shown that you can shape beliefs about bullying, about exercise, about environmental activism, and there's a great one about Earth Science Literacy Initiative in the U.S. to show how they could change people's thoughts about what science was about and change beliefs. I would really like to see us do this nationally, but this is going to require the provinces and the territories getting together because I don't see a lot of federal initiative around this. But I don't want us to be reinventing the curriculum in every province and territory. I think we need to share this. So let's move on to what you can do at the individual patient level. Okay, well, the first thing that everybody who gives immunizations needs to know is that the role of physicians and nurses giving the vaccine is incredibly important. It's your attitude very much strongly influences whether that parent, that child, that adult is going to get immunized. And we also know that parents who received information from physicians and healthcare providers were, instead of their friends and families and books, were much more likely to get immunized than those who only got the information from friends, families, and books. And when the healthcare worker information or assurances, they're the main reason why parents plan to defer or refuse vaccine, because healthcare workers can change that attitude when they work with them. But the really important point for all of us who work in programs are, you need to be aware of that healthcare professional whose own immunizations are not up to date, because they are unlikely to be pro-vaccine enough to help to convince those doubting parents and adults. So healthcare worker immunization has to be a key part of our strategy for addressing hesitancy. As any of you in healthcare know, whether a parent or an adult is going to believe you is all about trust. Do they think you're competent and know what you're talking about? And do you sound like you really care about them? You need to have both caring and competency together to engender trust. And sometimes we've got healthcare professionals who don't know enough to be able to answer the questions, or they may come across as not really caring about the people they're talking about. That can engender mistrust. So we've got to pay attention to that. As well, on the individual level, don't dismiss children from your practice over vaccine refusal. That's not going to help. We wrote a paper from the Canadian Pediatric and Child Health a number of years ago about this. There's legal, ethical, and public health issues. But the really important thing here is refusers are a very small minority in Canada. It's less than 1 to 3%. It's worth your time and effort, and it's in the child's best interest to keep having that parent coming in over other things and keep at them about vaccines. And if there is an issue that you can't address, then consider referring it to a vaccine expert. Or you might even also say the question, what will it take to get you to a yes about vaccine? Because sometimes you'll find it's not as hard as you thought it was going to be. One of the other things we know on the individual level is healthcare workers almost always think parents are more resistant to vaccine than they actually are. And this was a study from the U.S. emphasizing this point. And you can see the provider underestimated by a long shot a lot of what the parent actually valued vaccine to what the provider thought the parent valued vaccine. So the next point I want to make is probably one of the most important ones here from an individual healthcare provider point of view. It's the Tell, Don't, Ask study. At least that's how some of us have labeled it. And what Opal did in Seattle in this study is he showed that among vaccine-hesitant parents, if you use a presumptive method when you are talking to them, which is, well, we have to do the shots today and then move on, versus a participatory one is, what do you want to do about shots today? There was a huge difference in acceptance of those shots. With the presumptive one, 74% accepted the vaccine. With the participatory one, 4% accepted. And 13% of them gave their own strategies for how they wanted it done. And as others have said about this study, why would we ever use a participatory method when there is really only one medically acceptable choice? This isn't something where there is evidence that you should have a choice. There's evidence you shouldn't have a choice. There's evidence if you're not vaccinated, you can have a serious problem. So what about hesitancy not on schedule? You got a mother who comes in who says, well, I want to do it this way. Well, first of all, you need to go through and say a few things. The off schedules have not been tested. Secondly, the best evidence is based on the care for your child. Do you want me to give an inferior form of medical care to your child? And then from a complacency point of view, if that's the problem, it is important to be on time, and then you have to show them why. The measles outbreak in Quebec is a great example about why. And then it may be, if it's a convenience point of view, it's about access and about clinic times and stuff, you need to be thinking about how to fix those. And across all of these, you know what? One of the things we rarely ask, and we haven't done a good job about, is addressing pain. And it can be one of the underlying reasons why people are not immunized. So what about pain mitigation? Well, actually, at the time of immunization, well, Canada is a world leader in this area. In 2010, we published guidelines that were in CMAJ. They were the first evidence-based guidelines for pain mitigation at the time of immunization in the entire world, and have been picked up in many countries and followed in many countries. What you need to know is there will be a new update, a 2015 update to these guidelines that should be coming out, we hope, in the next couple of months. Look for it. I can't say for sure where it's going to be coming out, but I think it's likely going to be CMAJ, but I'm saying that very quietly. What's new in these guidelines? We give updates to the previous recommendations where evidence has changed. We've added in new strategies that were not in the previous guidelines. And best for all of you, we now cover all age groups, from neonates all the way up and through adults, where before we only did infants and children. There's also a great video, if you haven't seen it, that you need to go and look at. It is so cute. It is a 3.5-year-old telling you how she wants you to make her immunization injection experience better. She is ever so cute. Now, the last piece I want to talk about is using clear language and clarity in what you're trying to say. You need to use standard vocabulary. You know, the general public has no idea when you say something's common or something's rare. Rare for them may mean rare steak, which has absolutely nothing to do with immunization. So make sure you use language that they understand in the way they're using it. You need to be consistent about denominator. So for example, measles encephalitis happens at a rate of about 1 in 1,000 people who get measles. Encephalitis following MMR vaccine happens less than, may not happen at all, but it's less than 1 in a million. The problem for a lot of people is they're no good at fractions, and they don't know that a million is 1,000 times less than 1 in 1,000, and they get it all mixed up. So make sure your denominator is consistent. Make sure that you present risks and benefits fairly. Don't come across that you're being overly critical and undercritical of the vaccine. Explain single event probability. You either have measles or you don't. It's either raining or it's not. You either have tetanus and you die or you don't die. And yes, 10% of people who get tetanus die, but those 10% are dead. They're not a little bit dead, they're completely dead. And then don't use absolute numbers and relative risk. Most of us couldn't explain relative risk to people if we tried. So why do you expect the general public to understand it? And then frame your message. What do we mean by framing? Framing is presenting information of the equivalent outcome in terms of gains, that's the positive, or losses, the negative. So which hamburger do you want to eat? The 25% fat hamburger or the 75% lean hamburger? And I know all of you want the 75% lean, even though it's the same hamburger. But we need to do the same because we don't like things that are bad for us, the fat. So we're anxious about negatives. So we should be saying pneumococcal conjugate vaccine is more than 99.9% safe. It's much better than saying it has less than 0.1% side effects. And yet all too often we focus on the side effects and not on the safety of it. There are some parents who really, and adults, who want to know about how do you know the vaccines are safe. You need to tell them about the 8 parts of Canada's vaccine safety system and go through it with them if that's what they need to know how safe this is, and that we track and we follow. The other thing that's here, this is a video that was done by Romina Libster. She's from Argentina. I don't know how many of you will have seen it. Yes, it's given in Spanish, but it's got subtitles, and it is the most brilliant explanation of herd immunity or community protection that I've seen in a long, long time. And I think all of you should go out and see it. And for parents that really want to understand why they are not just protecting their child with the immunization, but why they're protecting others, this is a great video, YouTube video to send them to. So in summary, vaccine hesitancy is a global problem. It's complex. It's context-specific. It varies across time, place, and vaccines. And the approach to hesitancy has to be diagnose the problem, understand what's causing the problem, and work on that. Tailor a strategy to fit the problem. Assess the outcome, support resiliency of those who are proactive, and work for a next generation to be proactive. Thank you. And here, I hope, is one of the best quotes. Hillary Clinton on a tweet in mid-February versus the anti-vaxxers said, "The science is clear, the earth is round, the sky is blue, and vaccines work. Let's protect all of our kids." Thank you.
Well, thank you very much, Dr. McDonald. That was wonderful. Darlene, Virgo, do you have any comments or any?
Fantastic presentation, Noni. I miss being beside you at Grand Rounds, I have to say, in IWK. Can I ask you one question? One thing you didn't mention is this terribly flawed concept of balanced reporting in the media.
There's been a lot of work on that recently, Fergal, and the problem with balanced reporting, you should only be doing balanced reporting if there's balanced evidence on both sides. And for a long time, the journalists were saying, well, I want to make a story even if the evidence isn't balanced. But a number of them, many of the prominent journalists around the world are now recognizing that they're part of the problem. And they now, you'll see much more balanced reporting happening. So when the measles outbreak happened in California, it was fascinating to watch the media in the U.S. and the media in Europe over that and the media here in Canada. The anti-vaxxers weren't getting much of a voice, and in fact, they were getting attacked for having supported non-vaccination for this outbreak to have happened.
Fantastic.
It's fascinating.
And just a reminder to everybody to write their questions into the question panel. I have a few coming in here.
Can I also draw people's attention to the last slide if they can see it? These are some of the sites that might help you do it. And one of the ones that's down here, WHO Euro has a great little pamphlet which is called If You Choose Not to Vaccinate Your Child, Understand the Risks and Responsibilities for Yourself and for Your Community. It's a great little pamphlet. It's free. You can download it. That's the website I gave you there.
Great. And people are asking how they can access all these links. So we'll put them up on the Knowledge Exchange Network on the page that I shared at the beginning, and everybody will get, everybody who attends today will get a notification with the link to that page. So we have some questions here. Is it safe for unvaccinated children to continue at a medical practice if they put children who are too young to be vaccinated at risk?
Okay, just make sure I understand that. So a child who is not vaccinated coming to your practice, is that the question?
Yeah, are they putting
Yeah, they are putting other kids at risk who are too young to be immunized, so the children who can't have measles vaccine because they're under a year of age. So if you are in a period of time where we know measles is out and about, anybody who is not immunized and up to date should be at the end of your clinic or at the end of your practice day, because they should not be sitting around in your room when it could be possible that they're incubating measles. So if you're in the Laurendale region of Quebec and you were having you're practicing there or your public health clinic there, you would only want those people at the end of the day, because otherwise you're going to be continuing to spread. It is really problematic.
Great. And another question, what is the best approach to responding to health professionals that are vaccine hesitant or anti-vaccine?
I think let me do the vaccine hesitant first. I didn't have time to go into all the pain data, but we actually know that more than 40% of people are concerned about the pain with immunization. And for adults, not healthcare providers, but ordinary adults, at least 10% are so antenatal that they really don't want it. So one of the things you need to find out in a very non-judgmental way is, what are the reasons this person does not, why does this person not want to be immunized? What are the real underlying factors? Is it that they're afraid of the pain, because there are things we can do about that to mitigate it? Is it that they're concerned about side effects? Let's talk about that. Is it that they're concerned about, well, the vaccine disease isn't there? We can talk about that too. Is it that they need to hear more stories about what makes or doesn't make the problem go? So, Darlene, I'm going to be very careful how I say this, but in the last year, we had a child here who died at the IWK from influenza. That child had been in a healthcare center, not ours, for more than 2 years before. That child could only have gotten influenza in the healthcare center and probably got influenza from a healthcare provider. All right? That's a tragedy. Those stories need to be told, because I well remember this when I was at the Children's in Ottawa. We had a head nurse because we had a child who died from influenza. Again, very similar story to the one I just told. And she would not let anybody on her ward unless they had been immunized. Whether you were a medical student, a doctor, the pharmacist, it didn't matter. She'd stand at that door and she said, you're not coming in here unless you're immunized, because I'm not having you kill my kids. And it's interesting because CHEO has one of the highest uptakes of healthcare worker vaccine in the country. And that's a long time ago. Eleanor was the head nurse in the 1980s, early 90s. She really made a difference.
Noni, it's Elaine, and I knew exactly who you were talking about. That's a very important story to tell.
And, you know, because you have to find out why that healthcare worker doesn't want to do this. And you also, if they are hesitant, you need to have them understand that their behavior influences parents that they're dealing with and adults, patients that they're dealing with. And that is not right, that if they're making them less likely to be immunized, when it might be that child's or that adult's life you're putting on the line when they choose not to be immunized.
So I have a question from Calgary. It says, in Calgary, we are vaccinating the designer schedule, in quotation marks, those clients at one site downtown instead of the community health centers throughout the city. What are your thoughts on this approach?
Well, you know, I understand why a lot of programs have done this, where they move. It's what's the right word? It's to save money, make your program more efficient, in quotation marks. And the problem is, we do know that convenience makes a big, big difference. How easy you make it for people to get at vaccine changes your hesitancy rate and changes your uptake rate. The biggest example, actually, I can give you straight out of Calgary. When the bishop said that they were not allowed to give HPV vaccine to school kids in the Catholic schools, the uptake rate, even though the public health people had done a brilliant job of putting special clinics together for them to get it, they only had uptake rates of about 30%, way, way less than what was in the public schools where they could get it at school. I mean, it just shows you the difference. And then when they persuaded the bishop that, nope, this was wrong and they could give it at the schools, the rates went up, because it's convenient for adolescents to get their shots at school. It's very hard for a mother who's got 3 kids under the age of 4 to get that baby in on time when you're making it difficult. She's got to load all the kids in the car, take them all down to the clinic, and make it happen. I don't think we've really thought enough about the convenience barriers that we need to. And I would love us to see some studies done in Canada to really address those issues and see what is the best way. I'm not saying you shouldn't have one clinic downtown where the majority are going to come, but for the people that that doesn't fit, how can we make it easier for them to get immunized?
Right. I just wanted to, this is Lisa again, I just wanted to point out to everybody that we did actually have a presentation on those immunization pain guidelines. And that's,
oh, great.
Yeah. That,
you need to do a new one when the new ones come out.
Yeah, that actually was, Anna presented them yesterday.
Yeah. Oh, good. Excellent.
And they are the presentation was based on the new guidelines.
Great. Excellent.
So we will be posting that presentation as well. So we'll have,
and did Anna tell you that the new guidelines are going to be presented at WHO for global translation?
Yes, she did. I didn't know if I was allowed to say that, though.
We can only say that very quietly.
Okay.
Noni, this is Fergal. Could I just ask one more question about the education of this concept? Using your experience as Dean, how much of this is in the medical schools?
Not nearly enough. I don't think we teach in the medical schools, the nursing schools, the pharmacy schools. We don't teach enough about assimilation bias,
right,
and why people can have real anti-vaccine ideas. We don't teach enough about communication, and we don't teach enough about how you address these kinds of problems. And Fergal, we could be having the same conversation about why some people with diabetes don't manage their care very well. It's the same kind of principles, and we need to be figuring this out in a much better way.
And again, on education, I loved your reference to that American science literacy program. There's a similar health literacy program in Germany called Science Kids. It's still in a pilot, but interestingly, it is supported by and has been introduced and advocated by one of the big private health companies in Germany.
Yeah, well, I think a lot of people are starting to understand that we really need to be educating kids. And I'm not saying I want you to have a health course in primary school and secondary school, because it actually should be woven into the whole curriculum. So
yes,
there's a lot of history evidence for what happened in history because we didn't have vaccines compared to what happened after we had them. Okay?
Yes.
And we need to weave it all over the place so it becomes very normative. It's very much like what we did with the environmental movement, with the reduce, reuse, recycle environmental movement through the 80s and early 90s. And any of you who are young adults or who have kids who grew up in that era, you couldn't throw a tin can away without somebody harassing you who was a kid.
That's
and
right.
That's why the environmental movement has become so strong, because we educated a whole generation and the generation coming after about the importance of that thing, and we did it through school.
Yep.
It shapes beliefs.
Yes, it does.
So I have another question here, and I'm not quite sure I understand the question. Hopefully you will, or Teresa could maybe explain a little bit. So how do you listen to families that don't respond to phone calls or letters? So I'm assuming that if they're not responding to you, how can you respond to them very well?
Yeah, well, there are a couple of things about that. It's very hard to get them in. So if they should show up for any other reason, like for an acute visit, there needs to be a flag on that chart to say not to forget this piece. And again, it might be as simple as asking them a question to say, you know, your child is behind in their immunizations. What are your concerns? What will it take to get you to a yes and get your child immunized? Second piece is, if that person is, you know, part of a community that is against immunization or does not believe in a number of healthcare interventions, then you need to be thinking about how to work with the elders of that community on how to minimize risks for the community that's around them, and also what can be done to hopefully educate them about some of the issues about vaccine-preventable diseases. So let me give you a couple of examples. There are some very strong religious groups in the Netherlands who have subgroups here in Canada, in southwestern Ontario and in BC, who are very against vaccines and a lot of health care. But they tend to stay to themselves and they tend to school to themselves. But they do need education about should any of these vaccine-preventable diseases present, they are putting the rest of the community outside them at risk. And there are things that need to be done about that. And that needs to be worked on with public health and the leaders in those communities, because sometimes you can get the religious leaders to help you deal with the outbreaks when they happen, like it happened in Fraser Valley last year. It is not easy to deal with absolute refusers versus those that are hesitant. And that's why I talked about the continuum. Those that are hesitant are more easy to change than those that are out and out refusers.
Great. So another question here. So how is the plan of having programs supporting vaccine education in schools being received by the school boards, or is this thought still in its infancy?
Well, you know, we've done some work with school boards. I don't know how many of you know about the immunization poster contest that happened every 2 years that went with the Canadian Immunization Conference. That came with curriculum for grade 6 students. And, you know, we had more than 50 schools across Canada that have been doing it for a number of years and quite liked it and quite valued it. Now we're still looking to how this is going to get funded next time, but that's a whole other story. So I think we already have an in with a number of school boards who have accepted that program to say, this is how we need to think about it. But for me, it's a huge waste of time if we're going to have to do this school by school board by school board, province by province by province, territory by territory, and start from scratch. We need to probably pull together some kind of group, maybe it can be under CAF ceiling, that pulls together to look at developing this kind of a program, then looks at the best strategies for approaching the departments of education in each of the provinces and territories, and from thence down to the school boards. Because the other way around will just take us forever and take a huge amount of time.
And when you do it individually, Noni, it's Elaine again, when you do it individually, everyone sees themselves as unique, or we can't do it that way because it's different here, and yeah, so the national approach is
the way to go. And we
the way
know
to go
that,
for sure.
And when we did the reduce, reuse, recycle, that was a national approach.
Yeah.
So again, just to remind everybody, this presentation was recorded and it's going to be on CAFC's Knowledge Exchange Network, and we will send you the link to that. I don't have any further questions in yet, but please, if anybody has any other questions or thoughts, please.
And if you could join it up with the pain one, that would be great.
Yeah.
Lisa, so that they could go back and forth.
Oh, for sure, yeah. I'll actually have a few more questions that have come in now. What can we do to address healthcare professionals who do not believe in starting infants on vaccines until after 1 year old?
I think there's a couple of things we need to talk about there. We need to talk about this is not accepted medical care or nursing care, and I would be interested in the province that that's coming from if this is sanctioned by the College of Nurses or the College of Physicians and Surgeons in that province, because this would not meet acceptable treatment guidelines as recommended and advised by the National Advisory Committee on Immunization. So they would be practicing what would be considered substandard care. And I think we need to be thinking about it in that aspect. I'm not a pro-punitive person, but I think the people that are doing that need to understand that they are practicing unacceptable level of care, and should something go wrong with any one of those children, that they would be liable and would be unlikely to be defended by anybody. So any adverse bad events that should happen, vaccine preventable disease or other things, it's on their head.
Right. And do you have any tips for communicating with parents who have immunized their children in the past but are now refusing all vaccines?
Right, and so that's a very interesting group of parents, and a lot of them, you know, I talked about Web 2.0, a lot of them are actually usually very well educated, really go to the web to find out what they want to find out, and that's why offering them some of the web materials that I have here, or that the book, Your Child's Best Shot. The CPS has a brand new version of it that just came out, I think last week. Any of those things are often very useful for that kind of parent who is well educated and wants to know stuff. And what you need to sit down and talk to them about are two things. Why did you stop immunizing? Find out what that is. And if it's because they now, and I'm using this word carefully, believe that vaccines are dangerous, you need to say, let's sit and talk about the evidence, all right? And then let's talk about the evidence, show them the evidence, and also tell them some stories. So I have a wonderful story that I tell those kinds of parents. I had a child I looked after who was 3 years old. She came into the children's hospital and had tetanus. She had received her first immunization, had a febrile seizure. Her family doctor told her she should never be immunized again. She had an older sister who was fully immunized and a younger sister who was fully immunized, and that child almost died. That child was in the ICU for more than a month, and cardiac arrhythmias are what kill you with tetanus, and there's nothing we can do about it. And it's still a 10% mortality rate, even in the very best hospitals with the very best equipment and everything we know. And a lot of parents get a little bit stunned when you start telling them those stories and then start showing them the facts. But I find those parents often want the information themselves, which is why I send them to particularly good websites and books with information and then invite them back to come and talk to me again. You need to be very respectful.
And is there any data regarding vaccine hesitancy in families that deliver using a midwife as opposed to an obstetrician?
Okay, there is no specific study has looked at hesitancy with those two parameters, but I'm going to give you a side parameter of that which might help us extrapolate. Not always the best way to do data. We do know that families that are very pro-natural everything, even those that are very well educated, tend to be more anti-vaccine than those that accept that there are certain places where natural is not the way to go. So I would say somebody who used a midwife who wanted to deliver at home, who didn't want any interventions whatsoever, even if the midwife says, I think you should be immunized, is less likely to be immunized, but it's not the midwife's fault, is what I'm trying to say.
Yep.
In fact, most of the midwives that I've ever met or worked with here and in the UK have been actually very good about immunization. It's just that the people who want au naturel think au naturel disease is better, even if au naturel, they don't know that vaccine preventable diseases can kill and maim their kids. That's why we have the vaccines, to prevent them, because they can be so serious.
Noni, do you know if chiropractors in BC still are anti-vaccine to the extent that they used to have posters in their offices? Is that still occurring?
I don't know about BC. I do know that at the national college level, they are not anti-vaccine because, again, it would be malpractice. But I don't know about the BC ones. Maybe somebody from BC could tell us, but I don't know. I'm on the East Coast, Virgil.
Yeah. Lucky person.
Yeah, in the snow.
There's many people thanking you for this great presentation and hoping that they can share it further and share it to other families and other healthcare professionals. So this has been fabulous, Dr. McDonald.
Oh, you're welcome.
So in respect of time, I think I'll jump in and just wrap up the session if that's okay with everyone.
Yes.
So Dr. McDonald, thank you very much for bringing us your wealth of information and translating it into very measurable bites for us. That was great. Overviewing of the 10 strategies to help increase the immunization rates, as well as bringing in the heuristics and the current situation around the world, was invaluable to us, as Lisa said, with the number of accolades. So I'm sure if your contact information is posted, you may certainly get more contact after this session is over. So thank you very much for today's presentation.
You're welcome.
I would just add, Noni, that I think your endeavor, your dedication, and your communication is itself infectious.
That's a positive, Fergal. Thank you very much.
Yes, Elaine, I will echo that big time.
Well, so just a reminder to those on the audience that this the presentation will be posted within a few days up on the Knowledge Exchange Network. And for those of you who were registered for the presentation, Lisa will send a direct link out for that, so that's great for that. And just want to remind everybody that our next Patient Safety Collaborative call is going to be held on April the 24th, and the presentation will be focused on the use of iPads in the emergency department, and a study that is being done here at the IWK by Dr. Brett Taylor and his colleagues, and the focus on increasing communication for patient safety and everyone being on the same page. So that will be very interesting as well. And if anybody in the audience has any suggestions for future presentations, please contact Lisa, and we will do our best to bring those topics to the forefront and have a collaborative call on them. CAPC also provides a newsletter sent to your desktop computer or tablet, and it provides information of all of CAPC's webinar presentations, where you can find them, where you can find archived presentations. And on behalf of all of the folks at CAPC, Lisa, Elaine, myself, and my co-chair Fergal, again, thank you to Dr. Taylor. And we did have a special panelist on the line today. If Lisa, do you want to just briefly introduce her?
Sure. We had Lucy Bucci from Immunize Canada. She's a senior manager at Immunize Canada. And I have their website up on the screen. And they have a few tools and resources that people can use. I don't know if you want to say hello, Lucy, at the end of this call here.
They also have
Thank you very much. I want to thank everyone at CAPC and Noni for this wonderful webinar. I just want to take this opportunity to remind everyone that National Immunization Awareness Week is actually taking place at the end of April. It is a national campaign that is a collaborative effort with PAHO and the WHO. So this is something that we work very hard in promoting immunization during that week. And so we invite everyone to come and visit our website. We have free downloadable resources should anyone be interested. Thank you very much.
I just want to say that Immunize Canada has lots of great resources on their website that I think many of the listeners would find useful.
Great.
So that's excellent. And again, Noni, thank you for bringing this information to us. And I'll just throw it over to Elaine or Lisa if they have any final comments. And if not, we'll end the call for today. Okay, hearing none. I hope that everybody is on the line again for our April call. And happy spring to everyone.
Thanks, everybody.
Thank you so much. Bye, everyone.